Thank you. Welcome everyone to the Orthopaedic Academy combined with ORUK session today about scoliosis, presented by Mr. Zacharia Silk, who is the consultant orthopedic surgeon specialized in spine surgery in Oxford University Hospital. He is a member of the BASS and British Scoliosis Society, as well as he is a member of the Royal Society of Medicine. He was graduated from the Imperial College of School of Medicine with distinction and completed his higher specialty training in trauma and orthopedic in the Percival Pot rotation, during which he was inspired to pursue a career in spinal surgery. He has since completed the Integrated Orthopedic and Neurosurgical National Spine Fellowship in Leeds and subspecialist deformity fellowships at the Great Ormond Street and Royal National Orthopaedic Hospitals. He is he did an overseas fellowship, which was granted by the BOA and the AO Spine in New York, Philadelphia, and Bologna. He also now joined the consultant faculty in Oxford, and where he will continue his learning journey in the world of spinal surgery. After that, after his presentation, we would like to invite you all to participate in taking a part in the poll quiz. After that, we will ask any questions from the audience to Mr. Silk. So please, if there is any questions, you write it in the chat box, and I will ask Mr. Silk. Then we have interactive questions today instead of Viva, about 12 questions. So please participate in that by either showing interest in a private message to Hannah or Lydia or raising your hands. I would like here to promote the intensive FRCS trauma and orthopedics mock, Viva, and clinical exam courses. These courses are very important for the exam and help me personally to pass my exam. They are very well planned to address the exam type questions and to practice for you to practice before the exam and close enough to the exam. We have three, one in 9th of September, the other 14th of October, and then the 2nd of December. Please, if you show interest, you either go to the website or you can scan this QR code. Thank you. I will leave you now with Mr. Silk. Thank you.
Joe, thank you. Thanks for the introduction, and I really want to thank OR UK for hosting the event today, and also thank all of you for attending. I mean, we've got nearly 70 people logged in so far. So I'm just going to share my screen. Hopefully, we'll get a few more during the course of the event. And I'm just going to make a suggestion just early on. If anyone's keen to get involved in the interactive part of this, then just put a little asterisk, like rename yourself, and just put a little asterisk at a little star at the beginning of your name, and then at least we know who's keen to get involved in some questions later. So scoliosis for the FRCS. I mean, basically scoliosis comes under pediatric spinal deformity. We're just focusing on the top here, but for the purposes of the exam, I think it's really important to spend some time looking at Sherman's kyphosis and spondylolisthesis as well, because I think these are common clinical scenarios, both in the MCQ part of the exam, but also in the face-to-face aspect as well, because these tend to be stable patients who generally have a pain-free condition and would be suitable for examination. So, scoliosis, right. There's going to be a lot of unicorn references here because I did my fellowship in Leeds, so forgive me for this. But we are going to start with talking about the normal spine, and I mean, everybody knows that as a fetus or as a baby, you generally have a single curve. It's a primary curve where in the fetal position, you've got a global kyphosis. So cervical spine, thoracic spine, and lumbar spine tends to be in a kyphotic position. It's not really until the child starts developing that you start developing the secondary curves. So secondary curves tend to be start with the neck, so cervical lordosis. So as a baby is put into tummy time position, lifts head up, you get a secondary curve in the neck, and then as soon as the toddler starts standing a bit more confidently in the upright position, you get a secondary lordosis in the lumbar spine. So generally speaking, the vertebrae are wedged forwards, generally speaking. So these secondary curves develop as a change in the shape and morphology of the discs later on in life. Okay, but we have to try and understand normal before we look to abnormal. And so, I mean, most of you will understand that with respect to the thoracic spine, there are 12 rib-bearing vertebrae and usually 5 lumbar vertebrae. But there is also a variety described where you can perhaps get more or less rib-bearing vertebrae due to transitional segments between the thoracic and the lumbar spine, but similarly you can get the same between the lumbar spine and the sacral spine. So people have often heard of things like lumbralization or sacralization and so forth, but I think it's imperative in scoliosis to especially in clinical practice, probably less so in an exam, but certainly in clinical practice, to take into account these differences, because it does influence your level selection when it comes to surgery. So fundamentally, a normal spine has a series of 4 curves. We tend to be lordotic in the cervical and the lumbar spine, kyphotic in the thoracic spine and the sacrum, and in the coronal plane, so looking at the patient face on, there's no curves. And this is meant to give us overall balance of the head over the pelvis. So if one drops a plumb line through the center of C7 vertebrae, it should pass through the posterior superior corner of S1. That would represent normal sagittal balance or global sagittal balance, and that makes for very efficient gait, because if the center of gravity passes behind the hips, but we as human beings tend to carry most of our weight in front of the hips, then there is some balance between the two, and you're not, sort of the work of bipedal gait is a lot less and much more efficient. And there are some sort of ranges that you might want to commit to memory. So with respect to thoracic kyphosis, I think probably the fundamental one is really the 40-degree cutoff, because beyond 40, they tend to be hyperkyphotic, and beyond 60, you may be thinking about, sort of treatment for conditions like Sherman's kyphosis, if that is the case. But they don't tend to be kyphotic in idiopathic scoliosis, and I'll come to that in a minute. Whereas with lumbar lordosis, there's a general range between 40 and 60. So we'll focus on scoliosis. I mean, this is a sort of clinical photo and X-ray, which we'll come to a bit later in the talk again, so I won't dwell on that right now. But essentially, scoliosis, I think it's important to start with the definition. And as many of you know or can describe, it is a lateral curvature of the spine. And so side-to-side curvature of the spine. And there is a fundamental definition where that curvature is angled more than 10 degrees. So anything less than that is not technically defined as a scoliosis. They've got a lateral curvature of the spine, and maybe maybe due to mild leg length discrepancy, or it may be the start of a scoliosis and something that's been picked up incidentally on an X-ray for another reason. But I think it's important to just bear in mind that it is 10 degrees as the cutoff. And although we do describe it as a lateral side-to-side curvature, scoliosis is really a 3D deformity. So it's not just the lateral curvature, but it's also the fact that one develops a lordosis or hypokyphosis of the thoracic spine during the course of developing a scoliosis. And part of that, if one can understand, if you're looking at me from the side, as the spine grows lordotic, the center of gravity is sent so far backwards that the only way for the body to restore that center of gravity over the hips is to turn the spine about its axis. And so if I focus on there is a CT scan over here, and this is sort of typical CT scan of a patient with scoliosis, we can see how the vertebra has turned into the right hemithorax there. And what this would clinically be manifested by is prominence of the left chest wall. And so many patients, that's what they see. They see when they look in the mirror that they've got prominence of the left chest wall or the left breast. And parents often see what's going on at the back. So the right-sided thoracic cage is a lot more prominent. We call it rib hump or rib prominence. Rib hump sounds a bit, well, I don't think many patients like you calling them or saying they've got a rib hump. So I tend to use the word prominence. And it can, in severe forms, affect lung volume. So you can see how the vertebrae can really, sort of intrude into the chest wall and can cause kinking of the bronchial tree, as well as compressing the space available for lung development. And that's very, very relevant when we talk about early onset scoliosis. So scoliosis is common. I think that's why this talk has been put on, because it is absolutely examinable. 10% of teenagers tend to have a lateral curvature of their spine of more than 5 degrees. It's not defined as a scoliosis, but most of that is identified to be due to a mild leg length discrepancy and can be treated with a simple shoe raise. But patients with genuine scoliosis it gets lower as the curvature goes higher. So 2% have curves more than 10 degrees and 1 in 200 have a curve more than 20 degrees. And it's really not until one gets to that 20-degree threshold that you start being able to clinically notice it, or certainly to an untrained person, sort of 20 degrees tends to be that threshold where people can visibly see a scoliosis. So it's often picked up at that point rather than in the very early phases, unless there's an incidental finding on some imaging. Now, in terms of classification, so we've done definition, we've looked at how common it is, but I think it's important to talk about classifications, and there's obviously clinical classifications, there's some radiological ones as well, but with respect to clinical, I'm just going to keep it really simple for you and break it down so we can talk about the onset, so timing of when their scoliosis developed, also discuss whether the scoliosis is structural or non-structural, and then look at the causes, the different types of scoliosis. And then on the radiological front, it starts getting a little bit more complicated here. And I will briefly mention the Lenke classification, which is more relevant for idiopathic scoliosis, but there are some other classification systems for early onset scoliosis, and probably the one that will come up in the MCQ, I would expect, rather than Viva settings, would be things like rib vertebral angle difference, or the meta angle and rib phases. And I do remember this coming up in the MCQ based exam for myself. So in terms of age of onset, so in the past, idiopathic types of scoliosis used to be defined according to their age categories, and you may have come across the words infantile idiopathic scoliosis, juvenile idiopathic scoliosis, and adolescent idiopathic scoliosis, which is by far the most common. And I'm laboring on the point of idiopathic because some people do forget to use that word here, because there are other types of early onset scoliosis. But fundamentally, the reason they were categorized in this way was to categorize them according to the time of certain growth spurts. So you tended to have an infantile growth spurt up until the age of 3, and then juvenile between 4 to 9, and then idiopathic after puberty. And that really isn't of clinical significance. But what is of clinical significance, and this sort of change in the last sort of 20, 30 years, was the fact that people were identifying these patients according to their risk of developing pulmonary problems, so thoracic insufficiency syndrome fundamentally. So if patients were developing scoliosis early on in life, and the definition used to actually be less than 5 years rather than less than 10 years, but if it was less than 5 years of age, then they were really going to have problems with lung development. So this is where the SRS classification comes in. I think it's important to bear that in mind, and this is the up-to-date way of discussing the difference between early onset and late onset scoliosis, because also the treatment changes. So it's not just what pathology we're looking at, but with respect to early onset, we're looking at guiding their growth, versus late onset treatments where we're looking to fuse the spine, essentially, okay? So the second classification would be structural versus non-structural scoliosis. So a non-structural curve is just, somebody without a scoliosis essentially bending side to side. Often these patients have leg length discrepancies, or maybe trying to offload a level of the spine where they're suffering with sciatica. So if they've got protruded disc on one side and leaning to the opposite side relieves their pain, then they may develop a non-structural scoliosis. And often if you treat the underlying problem, it reverses, it can get better over time. And often with these patients specifically, they don't have the axial rotation component of a structural scoliosis. So a structural scoliosis is one that measures more than 10 degrees, which we've discussed, but with axial rotation of the posterior element. So when you look at the X-ray, you do see that the pedicles are turning with respect to the vertebral bodies, and the relationship of the pedicles and the spinous process, which is normally in the middle of the two pedicles, it changes. So that's where you want to keep an eye, and that's what would be defined as a structural curve. Now, I think if anyone's read the Lenke classification specifically, well done. I would say I need to highlight that in his classification, or in that classification, they talk about a non-structural curve being less than 25 degrees when you bend. That's just relevant to the surgical management, but a truly non-structural curve restores itself to 0 or beyond, okay? It has to restore itself to 0. That's a true non-structural curve, but for the purposes of definition, Lenke's classification describes it as being less than 25. I'm happy to go through that at the end if anyone's still confused by that, but I just thought I'd better mention that because there is some subtlety there. So in terms of etiology, I think this is probably last of my. We're basically ramping up in terms of the intensity of these kind of classifications. So in terms of etiology, most common cause, so 70% of what you're going to see in a clinic is going to be idiopathic, but there are congenital causes, and this could be due to a failure of formation or failure of segmentation or a bit of both, so a mixed pattern. There are neuromuscular causes, and you can break that down into neurological causes and myopathic causes, and there is sometimes some overlap between neuromuscular scoliosis and the syndromic type. So syndromics tend to have genetic conditions that are a bit more widespread. They, with multi-organ involvement, and not necessarily just restricted to the neurological or central nervous system and the peripheral nervous system and the muscles. In terms of traumatic, I mean, that's sort of very uncommon, and pathologic, again, very uncommon, but we do see this from time to time. So painful tumors of the spine can cause a scoliosis. The typical one would be something like an osteoid osteoma or an osteoblastoma would be a typical pathological cause of scoliosis, but it tends to be that non-structural type where they're just trying to offload the painful side of the spine. And if you treat that, it tends to reverse. Okay, so this is available on the web. It's also available on Ortho Bullets. This is the Lenke classification. I do not think, for the purposes of the exam, you need to learn the insides and outs of the Lenke classification. But if you want to just have a basic understanding of it, I think it's important to just break it down. So it does talk about different curve types and where those curves are. So in the thoracic spine, we tend to break down the thoracic curves into two. So there tends to be a proximal thoracic and a main thoracic, depending on where the apex is. And then there could be a curve in the thoracolumbar or lumbar spine. Thoracolumbar specifically has an apex between T12 L1 disc space and L1, and anything below the L1-2 disc space in terms of apex is classified as the lumbar curve. And then, so there's a combination of those curves. there's a lumbar modifier, which basically just gives us a sense of the severity of the lumbar curve. So how far the lumbar apex is deviated from the midline, and a sagittal modifier, which looks at their sagittal profile and balance, and whether they have any kyphosis across the thoracolumbar junction. So I'm not going to dwell on that too much because, like I said, I don't think this is important for the purposes of the exam, but nonetheless, it's good to be aware of it. So we'll move back to our clinical case, and essentially the way I'm just going to work through this is just talk you through some of the elements of the history and the examination that I think are important for you to capture in your consultations, whether it's in an exam setting or a real life setting. So the way I would tend to go about it is try to find a history about the deformity itself. It tends to be apparent, and you try to find out whether or not it was early or late. So before or after the age of 10, I think is relevant. And try and find out what the main concern is, not just for the patient, but also for the parent. Because I mean, I very frequently come across patients who are referred in with a scoliosis, but their primary concern is pain. And it may be mechanical pain, it may be non-specific, it may be related to a sinister cause of their scoliosis, but pain is very different to the cosmetic aspects of the deformity, which you know, sort of lead you down a different treatment path. So I think it's important to just identify the main concerns before you sort of move forwards with your clinical evaluation. The other things that I tend to look at in the history and examination as well is just try to get a sense of what their likely skeletal maturity is. So in females, you can ask about the onset of periods. A great question that one of my mentors used to ask some of his patients was, when was the last time you needed to change your shoe size or get some new clothes? But fundamentally, shoe size was seems to be, you know, one that people recall quite often. And then try and find out a history of the potential underlying cause. Okay, I think this is important. So, I mean, they may have past medical history themselves or not. There may be a family history, which is important to figure out. Okay, so especially when it comes to syndromic causes, things like Marfan's, neurofibromatosis, you want to kind of think a little bit laterally with respect to their causes. And a pediatric history, it's important to go through this, especially if you're dealing with a non-idiopathic or suspecting a non-idiopathic cause of their problem. But if anyone is to mention pain, you must rule out the red flags. Okay, you've got to think about tumor, think about infection, and you know, sort of quick screen is absolutely essential. So moving on to examination. So again, similarly, I tend to break this down into an examination of the deformity itself. So you can break it down by looking at the patient from the front, the side, and the back. And you can do that in the sitting and the standing position. So the relevance of that is, and I've had this in some of my Viva practice, is if you've got a patient with a profound scoliosis and a leg length discrepancy, one of the crucial ways to obliterate the leg length discrepancy as an issue is to sit the patient down, because as their ischial tuberosities are level on the couch, then you'll be able to see what the residual deformity, so suprapelvic deformity, looks like. And some of that does correct. And some patients will just have a combination of both. So other things are going to be looking at top, shoulders. So look at the neck and the shoulders for symmetry on both sides. Look at the chest wall, look for the rib prominence, both at the front and the back of the spine. Look at the waist. So we're just working our way down. Look at the pelvic height, and look at the spine itself to see whether or not they're kyphotic or lordotic. And lordotic, like I say, is the most common thing here. You can feel for tenderness, percussion tenderness as well, especially if you're concerned about tumor. And in terms of movement, I guess the key maneuver is the Adams forward bending test, which I'll come to shortly. There are other aspects you can assess on exam. So skeletal maturity, other, you know, secondary sexual characteristics. I mean, obviously with a chaperone, but a lot of this will be, you know, sort of obvious to you, I think, when you examine these patients. And then there's going to be things like, you know, other causes. So atypical deformity. So if they've got a very short and sharp dystrophic curve, if they're kyphoscoliotic, these are really atypical. If they've got things like arachnodactyly, a long arm span, high arch palate, lens dislocation, sternotomy scars. I mean, you're thinking about Marfan's with that one. So, same for neurofibromatosis. Look in the armpits for axillary freckling, actual sort of cutaneous neurofibromas, cafe au lait spots, lesion nodules in the eyes, optic gliomas, and what the parent looks like if they're in the room with the patient, and spina bifida, or spinal dysraphism, so hairy patches, dimples, and scars. It's important to pick all of these things up, so you can look, you can feel for a collapsing pulse, and you can assess if you're concerned about connective tissue disorder, assess for hypermobility syndrome as well. But I think the other aspect is neurological assessment. So I've put here abdominal reflex. I mean, abdominal reflex has been described and has been shown to be associated, if it's absent, associated with an intraspinal pathology. So it may be suggestive that the patient may have a Chiari malformation or a syrinx or a tethered cord. So if it is absent or asymmetrical, I think that might prompt you to want to do an MRI scan quite early on that patient to exclude an intraspinal driver for their scoliosis. Some of you will have heard of the Tanner stages of development for secondary sexual characteristics. I'm not going to dwell on that too much, but the crucial special test in your exam is going to be the Adams forward bending test. Again, that essentially allows you to take away the gravitational pull on the spine. By just bending them forwards, you can actually reduce the non-structural component to their scoliosis. So everybody with a scoliosis, a structural scoliosis, is going to have a non-structural part to it as well, a part that's reversible. But the stuff that's left behind is structural, and that's what you're looking for on the Adams forward bending test. And what you can see here when the patient is bent forwards, you can see asymmetry in the height of the chest wall, and you can palpate that. You can also put a scoliometer on that, so that's a useful device, and you can also get these apps on your iPhone to allow you to measure that. But in an exam, you may find one on the side table, and it would be absolutely reasonable for you to pick that up and just measure their deformity. There are some other special investigations you can do, non-invasive ones, so topical assessments like an ISIS scan, but fundamentally where you're going to, so when you go down the investigation route, you're going to be looking for whole spine radiographs, and a whole spine radiograph is meant to be a whole spine radiograph, but as a minimum, you want C7 to S1, and you want the full width of the chest, and you want the hips on show. And the reason you want the hips on show is that it gives you a sense of skeletal maturity. So you can look at the triradiate cartilages, you can look for a leg length discrepancy, and you can look for the Rissa sign on the iliac crest. But people are often concerned about radiation exposure, etc. There is sort of in the future things like EOS, which is like a slot scanner, very low dose scanning system that allows you to more safely, I guess, assess scoliosis, because many of these patients require imaging every 6 months, and it is associated with an increased risk of cancer development. So if you're looking at X-rays, I mean, there's sort of a number of things that you can look at, and I've got another slide that will just sort of better demonstrate this. But there are various lines, things like the center sacral vertical line, which is essentially a vertical line that's drawn upwards from the center of the sacrum, and allows you to see how far the apex is deviated away from that. You can do a Cobb angle measurement, and I'll go through that as well shortly, where you're looking for how angled the curve is. And there's other things to look at, so where the apex of the deformity is and where the concavity and the convexity of the curve is. And there are other measures like the sort of the rotation, vertebral rotation, and the relationship of the pedicles, the spinous process, and the vertebral bodies, which do come up in the MCQs, but these are very rarely used in clinical practice, so I'm not going to dwell on them today. So in terms of radiographic interpretation, so I've got this X-ray up. I think a crucial thing to pick up is that the left is on the left as you're looking at the back of the patient. So the most scoliosis X-rays are typically presented in this way. I think it's really important that you do orientate your right and your left, because obviously you're not used to looking at a frontal X-ray of the chest back to front, and normally the right is on this side. So I just want to point that out. It tends to be PA as opposed to AP. It's difficult to, and this is a PA, and part of the reason for a PA radiograph is that it reduces the, I guess, the sort of radiation to the breast tissue. So if the X-ray beams are coming from back to front, it reduces that, and it's thought to reduce cancer risk. So they tend to be PA, and they tend to be done in the standing position. And so the things that I look for is going to be their curve. So this person's got a main thoracic curve, they've got a proximal thoracic curve, and they've got a lumbar curve. Okay, I want to look at the severity of their curves and the apex of their curves. And so if you were looking at the apex, I mean, if you just drew a horizontal line upwards, you'll see where that horizontal line touches, and it could be a vertebra or it could be a disc space. And then there's other things to check, things like balance. So we talk about coronal balance. There's also sagittal balance on the lateral view, but coronal balance will be dropping a plumb line from C7 all the way down, comparing that to another line that you draw from the center of the sacrum, the CSVL, all the way up, and seeing whether there's a difference between the two. And, you know, up to 2 centimeters is perfectly fine, but beyond that, it can be noticeable. And you can look at the balance of the shoulders as well, and the balance of the hips. There are some anomalies to try and pick up on your x-rays. So segmentation and formation anomalies, if you do see those will prompt you to do further 3D imaging quite early on. Count up your vertebrae and count up your ribs, just make sure they're matching. And with respect to skeletal maturity, and I'll come to that in a second, things like rissa, triradiate cartilages, and if you've got the hand either on view on this image, so some people have described just having the hand in the picture, just so that you can try and focus in on the growth plates of the hand, or doing a separate hand x-ray, you can assess bone age that way. So with respect, we're moving on to cob angles. So there are some practical aspects to the cob angle. If I very much doubt you're ever going to be asked to draw one in an exam, but I think for clinical practice, it's important to understand. So there are 3 main steps. You've got to try and find the end vertebra. The end vertebra basically is the top and the bottom of each curve, and that can be quite. It can be harder in practice to figure out than some may think. So. I'm just going to sort of go to the next slide, actually, really, because I think that describes what I want to say a bit easier. But essentially, the end vertebra is the most tilted vertebra. Okay, it's the most tilted vertebra, and so the way I end up working that out is I basically follow the convexity of each curve, right? And what you end up seeing is that, and I'm sure you can see my arrow. You can see one disc space is wedged open. So I'm not looking at the vertebra, I'm looking at the disc space. So this disc space is wedged open, that's closed, open, closed. I've got my arrow there, that's open, that's closed. It's difficult to say what's going on here at the moment, but this is clearly open on the opposite side, yeah? Opposite side, and that's closed. So something has happened between these 2 curves. And if you really zoom in on this, you could probably say this is a bit more open than this side. And so as you switch from open, closed to open, closed, that would mean that this is the end vertebra. Okay, and the end vertebra, this is an end vertebra for this curve, and this is an end vertebra for that curve. Okay, so you can have one end vertebra for 2 curves, and where you end up doing your measurements from will be at the top of the end vertebra for the bottom curve, and the bottom of the end vertebra for the top curve. So I hope that, you know, if any of you have struggled with cob angles, that just makes sense. But essentially what you're looking for is the transition between the wedging, so the opening and closing of the disc space on one side of the spine, so the opening and the closing of the disc space on the opposite side of the spine. That is the transition point from one curve to the other, and that vertebra, where it's different on both sides, is the end vertebra. Rissa sign. So rissa sign is it's quite a crude way of assessing skeletal maturity, but because the pelvis is easy to visualize on an X-ray, it is the most common way that we look at things. But RISA 0 is essentially before any of this shows up. So this iliac crest apophysis, this doesn't appear until 2/3 of the way along your pubertal growth spurt. So you've missed quite a long period of time before you see the iliac crest apophysis appear as a RISA 1, and it's divided up into quarters. Okay, so RISA 1, 2, 3, 4 will take you all the way to the back of the pelvis, and then once it's at the back of the pelvis, it tends to knit its way, it tends to fuse down to the ilium from back to front. At least that's how I've seen it, and so that will equate to RISA 5 on the opposite side. And for girls, girls tend to be considered skeletally mature at RISA 4, and boys tend to be considered skeletally mature at RISA 5. And that's relevant when it comes to sort of treatment or and decisions about treatment, certain types of treatment. A slightly more accurate way of looking at things, and this is something that I guess I'm more frequently using in my practice now, is hand X-rays to look at bone age, but specifically look at the growth plates, because there is an association between the closure or the development of the growth plates in different parts of the hand and your RISA sign. And for me, if I see somebody who's like a RISA 1 or 2 and I'm not sure if I should brace them, and I do a hand X-ray, it will tell me whether or not I've got enough opportunity to modulate their growth or not. Because what you don't want to do is to put somebody unnecessarily into a bracing program if they're too skeletally mature. And I think just RISA is probably not good enough in terms of giving you a sense of that. But here we've got like a growth velocity and height gain sort of diagram. It's just to give you a sense of where things are. So girls tend to sort of go through their pubertal growth spurt a lot sooner than boys. Most commonly we would say between 12 and 14, and by 14 they tend to stop growing, but boys it tends to be later, usually between 14 and 16. But if we have a look at this growth chart, so RISA 0, triradiates open, that's when you really accelerate with respect to your growth rate. And it continues accelerating up until the point that your triradiate cartilage is closed. So you can see here that once you drop into RISA 1, that's when your growth rate starts declining. And so from my perspective, anything between 0 and 2 is high risk for progression. 3 is kind of in the middle. 4, 5s tends to be not much progression, or certainly not much progression in the short term. There are some other X-rays. So we've talked about, I guess, the standing whole spine X-ray. I think it's also important to bear in mind that for surgical planning, it's very helpful to have some, I guess, traction or flexibility assessments of the spine. So you can clinically assess them with respect to their flexibility, but it's nice to be able to measure that, so you know whether or not you're going to need to do additional work or take additional steps at the time of surgery to release the spine. And that may be involving quite substantial releases of the discs as well as the facet joints at the back of the spine, or it could be that you just do facet joint resections at the back of the spine alone. And so a flexibility assessment can be done with you pulling the patient. So this is a traction view. There are other ways to do this, like the fulcrum bending view. Again, this is a bit much for the exam, but it's just to give you a practical sense of some of the options that might be out there in your units. And what you end up seeing is this is the curve before and how it bends out to 48 degrees from 73 degrees. And, from my perspective, that also gives me a sense of, whether or not it's going to be, what the clinical outcome is going to be at the end. You can really have a conversation with the patient and say, well, this is very flexible. This is where it's going without any release and without the addition of screws and rods. So the likelihood is I'll be able to get it straighter than this. Or if they're not moving at all, then you can give them fairly guarded prognosis, okay? So we'll go back to our case. I mean, briefly, if I was going to describe this clinical scenario to you, so examining this young girl from the back, I can see she's got left shoulder elevation. She's got prominence of the right thoracic cage and the scapula. She's got asymmetry of the waist with flattening on the right-hand side, a more prominent left hip, and she's got a loin crease. Okay, and when she bends forwards, we can also quite clearly see that she has a rib hump here, or rib prominence on the right side, consistent with the diagnosis of structural scoliosis. Okay, and if you went to town on this, you would say, well, there's no features of Marfan's or neurofibromatosis to suggest an underlying cause, but then you go on to do an examination of their neurological system briefly, okay, just looking for upper motor neurone signs specifically, and the absence of the abdominal reflex. And then with respect to the radiograph, so looking at this radiograph, it matches up clinically quite well in the sense that she has left shoulder elevation, she has truncal shift. So the chest, if I look at the chest, if I draw a straight line down from the outside of the chest, it doesn't fall on the outside of the pelvis, which it should line up with. So the trunk itself has shifted. You can see with respect to the soft tissue shadows that there's asymmetry of the waist. There's maybe a mild leg length discrepancy, but not that significant at all. And then looking at the curve, she's got a structural, I haven't measured this, but it's fairly sizable, structural, proximal thoracic, main thoracic, and lumbar curve as well. So we're going to move forwards to, I guess, treatment. So the fundamental questions you need to be asking, or you will be asked, is whether or not you're going to be doing surgery for this patient. And so you could do an operation, but I wouldn't jump straight to that in your examination answer. You could brace them, okay? And so with respect to bracing, curves between 20 and 40 degrees or 20 and 45 degrees tend to be braced, especially if they've got a risk of progression. I'll go on to that in a second, or you could just simply observe them. Okay, and if there's one paper you need to be able to quote from the literature, I think is going to be this one. It's the BRACE trial. It was a randomized controlled trial comparing active observation and bracing in patients with idiopathic scoliosis with curves between 20 and 40 degrees. And essentially the failure point was if their curve had reached 50 degrees or they went on to have surgery. Okay, and what they found is that there is a sort of significant benefit to having a brace. So if patients are wearing it for extended periods of time, so more than 17 hours, ideally up to 23 hours in the day, they're getting the best results, and there's 90% success rates with that. But patients who are not using it regularly or during the day, they may as well not be wearing it at all. Okay, so compliance is super important for these types of patients. But also at what cost? One needs to be considerate of that, because braces are not completely benign in terms of treatment. There are issues with skin. I think at their age, so especially teenage years, psychosocial effects can be a massive problem. There's a lot of stigma associated with this, and also there's a feeling that they may also get sort of disuse atrophy of them core muscles and go on to develop problems like back pain and so forth in the future. But I think one thing to be, sort of quite excited about is that the UK has is sort of, I guess, first in the world to compare two different types of braces, so full-time versus a nighttime brace, which hasn't got any significant experience. We don't have any significant experience of that here in the UK, but it is used in other parts of Europe, and we're looking to see whether or not the nighttime brace compares favorably or in a similar way to performs in a similar way to a full-time brace, because for some children who really struggle with the idea of wearing one throughout the day, this may provide them with a second option so that they have a brace just at nighttime alone. Okay, so in terms of your surgical decision making, I mean, we'll just go through the algorithm that I use, but fundamental thing, like I say, the first question at the beginning of this is, But what is it that they want? Are they really concerned about cosmesis here, about the size of their curve? You want to have a sense of whether or not their curve is going to be progressing. Before and also after maturity. So if they're not skeletally mature, risk of 0 to 2, you are really concerned that there is going to be progression. If they are skeletally mature and they've got a sizable curve, so a curve more than 50 degrees, I mean, it's probably even less now. I think there was a recent paper published in the BJJ, Bone and Joint Journal, which shows that even milder curves continue progressing into skeletal maturity. I mean, there are limited papers that have looked at long-term, sort of long-term follow-up on these patients. But the classic is if you've got a curve more than 50 degrees at skeletal maturity, you're likely to progress by half a degree to a degree per year. But I think there is fairly good evidence that that can even happen at lower degrees of severity. Then you can think about what approach you might use. So if you were thinking about doing surgery, are you going to do this just from the back, the front, or a combined approach, depending on, I guess, curve size and curve stiffness? I think a composite of those two would inform your decision. And then in terms of what levels. Now, with respect to fusion levels, I mean, we could talk to all evening about fusion levels. I'm not going to dwell on that here, but the fundamental take home is that we tend to just fuse the structural parts of the curve. Okay, we want to leave as much of the non-structural moving parts uninstrumented so that it doesn't take away too much function. So broadly speaking, if a Cobb angle is less than 20 or 25 degrees, observe them. If it's anywhere between 25, I've got 35 for some reason here, but 25 to 45, you can brace them. If they're skeletally immature, if they're mature, so 3 and beyond, 3, I wouldn't bother starting a brace, it's probably too late. But certainly 4 and 5, you could offer surgery if they're severe enough, or you could just observe them. Okay, and these are the goals of surgery. Okay, so the primary goal is really to correct deformity, but also to prevent the progression of their curve. I think that's what I always tell patients. I'm offering you an operation or an opportunity to prevent this from getting worse. The bonus of that is that I can correct the deformity at the same time. I'm looking to do this in a way that maintains your center of gravity, or your alignment of the spine, so the head, the chest, and the pelvis all line up nicely. And I want to do this in the way that also levels your shoulders out, especially if they've come to you with shoulder imbalance. And I'm trying to preserve as much motion as possible. So although you can make them have a very nice straight spine on an X-ray by fusing lots and lots of levels, it doesn't necessarily do well for them. So all of these should be taken into account of, I guess, if you were talking about the goals of scoliosis surgery. And these are some of the results you might see. So this is a posterior instrumented fusion. These are pedicle screws, and these are rods which are used to correct just this structural element of the curve and this non-structural bit. So we don't have a bending film to show you, but if we did have a bending film of this, I would expect it to bend out to less than 25 degrees, if not bend out completely straight. And if it does do that, it gives you a fairly decent amount of confidence to go in and do an operation that is limited to just the structural element of their spinal curvature, because this is spontaneously corrected, and that's a great result for this patient. Some may have heard of this is really old now, but nevertheless, we still don't have this available on the NHS. It's just available for research purposes. But vertebral body tethering is sort of an emerging treatment. I think the evidence is still fairly limited to justify its use, but I guess it is similar to how one would think about 8 plates on the knees for treatment of various or valgus deformities, whereby people are essentially tethering the convexity of the spine from the front. The idea being that you're trying to increase the pressure in the growth plates on that side to inhibit growth and allow them to grow on the opposite side. But the problem with any sort of, I guess, mechanical device being applied to a moving joint or spine is that it's going to be under mechanical load all the time and subject to failure. And so there's very high failure rate documented with this procedure, and a fusion operation, especially if it's just restricted to the thoracic spine, probably is just as good, if not better, than vertebral body tethering, like this motion preserving procedure, because you don't really move that much through your thoracic spine anyway. So so where its benefit would be ideally seen would be in the lumbar spine, if that was feasible. But again, you're putting more weight, more pressure through the lumbar spine for this. So I don't think this is, again, I don't think this is particularly relevant for the exam, but it may be something of interest to you, just to show you that there are some emerging technologies looking to modulate growth in a similar way to how we're used to doing this in other parts of the spine. And this is, so I guess this is just an X-ray just for completion, just to show you you can't actually see the tether on there. So somebody's actually just drawn that in there in red, because it's obviously a see-through plastic cord. So we're nearing the end. I hope people are still listening. I think Joe has got just some sort of MCQs that he's just going to quickly put up and share with you guys. And then I've got sort of a dozen quiz questions. So if people are keen to get involved in a bit of an interactive chat, then we can do that then. So why don't you guys just have a crack at this. Some of this I've not actually covered in the talk. Some of it I have, but it'd just be interesting to see how you all get on with these questions. So we'll just give you sort of a couple of minutes. I guess, Joe, have you got any questions on the chat? Just while we're...
Yes, there's few questions on the chat. First question is, how do you do an abdominal reflex?
So I think the key thing is to get the patient exposed properly. So they do need to lower their trouser waist or underwear just down to the waist. And essentially there are 4 quadrants you want to test. And the way I do it is just use the sharp end of a reflex hammer. Start at the level of the belly button and go away in 4 quadrants. And essentially what you're looking to see is the contraction of the belly button towards the side that you've scratched. So there'll be a small little contraction there. That's how to do the abdominal reflex.
The second question is that, is there an age threshold for a surgical management in adults with symptomatic scoliosis?
So it depends on the cause. So we've talked about, I guess, sort of pediatric scoliosis. So the one cause of scoliosis in the etiology section that I didn't mention is degenerative scoliosis. So it depends what we're talking about. If we're talking about untreated pediatric scoliosis, and many patients are untreated, or they're treated with braces or active observation, and later on in life develop problems. There isn't a, I wouldn't say there's a threshold for treatment in terms of age, but their symptoms differ. So in early presentation, they may be talking about deformity and appearance. Usually it's appearance that's the primary concern. Later on in life, it tends to be pain, but their pain tends to be a lot more different at that stage. So if you're loading your discs in an asymmetrical way for a long period of time, you may find that you develop early onset arthritis within those intervertebral joints and the facet joints, and they can develop pain. And so you will treat them just as if you saw, as you know, sort of any back pain patient, physical therapy, painkillers, facet joint or blocks or injections and nerve roots as needed. But if that fails, then you're talking about surgical options, but you're doing surgery to relieve them of pain. It's different. Like I say, it's very, very different just in terms of the goal for the adult patient compared to the pediatric patient. And so that's the untreated pediatric cohort. And then there's the degenerative cohort, which is, they present over the age of 50, 60 with de novo changes in their discs. So they've collapsed in their discs at multiple levels for a number of reasons. And they are, again, suffering with pain, but a different kind of deformity. So I've mentioned that the pediatric scoliosis patient tends to develop a lordosis. and then to deal with the lordosis, they twist their spine to try and keep it straight and upright. The degenerative patient is very different. Their discs fail, okay? And then once their discs fail, they start developing a rotational abnormality in the spine and scoliosis with that. And so they develop kyphosis. That's why the phrase kyphoscoliosis is always an atypical cause of scoliosis or pathological cause of scoliosis rather than lordoscoliosis, which is the description of an idiopathic type of scoliosis and the most common type of scoliosis we see. Yeah. Before we take any more questions, shall we close the poll and just run through these quickly?
Yeah, I believe that's enough for the poll.
I guess we're sharing the results with everyone. Yeah, we are. Yeah. So yeah. Meta angle. So meta angle. I mentioned it very early on in the talk. Basically, Meta was a surgeon or a physician in the Royal National Orthopaedic Hospital, and I guess her life's work was the treatment of patients with early onset scoliosis or early onset idiopathic scoliosis, and essentially what she described was I guess like a prognostic feature on the X-ray. So on the frontal X-ray called the rib vertebral angle difference. And so it's worth looking this up. But I think, Joe, I mean, you wrote these questions, but I think it's the third one down. Difference between the two rib vertebral angles would be the right question. So it's quite a varied response here. So it would just seem that I think people would want to go and look at that. And it does come up in the MCQ. So early onset scoliosis, the rib vertebral angle difference, and also the different rib phases, which is also another feature that she described. And these are basically like at-risk signs of progression, and they will determine whether a patient will need treatment or observation alone. If we move to the second question, there's the type of congenital scoliosis most likely to progress. So the majority of you got this right. So a fully segmented hemivertebra on one side has a disc above and a disc below, or above and below. And so they've got two functioning growth plates on either side of that. And so that is going to progress. But if you've got a unilateral bar on the contralateral side, or a bar on the bar is basically just a failure of segmentation on the contralateral side, you're going to progress at a much higher rate. So that's the one that work with the worst prognosis. And then yeah, the majority of you got this right. So neurofibromatosis is so one of the many syndromes that is associated with scoliosis, and it's quite classic for us to see vertebral scalloping on an X-ray, penciling of the ribs, and enlarged foramine. Part of the scalloping in the foramine is due to a condition called dural ectasia, which is visible on an MRI scan. And I mean, I've seen some absolute disasters with this, where essentially they lose a lot of the structure of their vertebral bodies and pedicles and posterior elements. And so when they do come to you with a problem with scoliosis, it's very difficult to get fixation or anchor points in their spine. And also neurofibromatosis, many of you will know, is associated with pseudoarthrosis. And so they've got a 40% chance of non-union, even with scoliosis surgery. So there would be an indication in this particular cohort of patients to do an anterior base fusion as well as a posterior base fusion, or bring them back 6 months after their original primary surgery to regraft them because of their high rates of non-union. So I thought it's a good question. It's a good one to mention, because that, again, is something that might come up in the MCQ part of the exam, but it's probably not relevant for the clinical. Okay.
There's a few more questions, if we can go through them quickly. Is that okay?
Let's go through those quickly, yeah.
Yeah, so a bit of clarification about the risser quadrants on the pelvic, please.
Yeah, so let me see if I can just get that up. So, sorry, just give me a second. Here we go. All right, fine. So yeah, risser signs. So I mean, you basically divide the iliac crest into quarters. So 0 to 25, 25 to 50, 50 to 75. Yeah, 75 to 100. So it normally starts at a 0. So you're not going to see this line. So this is the iliac crest apophysis. You're not going to see it at the beginning. So 0, and look down here, we can't see it on this x-ray for the triradiate cartilages. So if they're open, they're almost certainly a 0, okay? If they're closed and you don't see this, they could be a 0 or they could be a 5 because they look exactly the same. So the only way you're going to tell the difference on that would be, you know, sort of history with respect to menarche, secondary sexual characteristics, and a hand x-ray. But yeah, so essentially the FRCS hypothesis starts at 1. So 0, 1 is when it first appears, goes all the way to 4, then it starts fusing down to the ilium. Okay. Good.
Thank you. Any specific points to mention while consenting for scoliosis?
Yeah,
No.
You know, there's a lot to go through with scoliosis. I think the thing that, you know, you really need to deal with up front is the one that scares people the most, and it's obviously paralysis. I think is the one that's really, you know, thing that scares everybody. And that could be temporary or permanent. It could be related to your implants, so implant positioning. It could be related to the actual correction, so the maneuver of correcting the spine, which has been in a curved position for quite some time. And if you stretch the spinal cord, it may not like the new position it's in. But there's also, you know, sort of technical aspects. There's anesthetic reasons why they may get spinal cord dysfunction during the course of their operation. And so it brings into sort of the discussion that the importance of using neuromonitoring, which is used for every single case certainly in the UK, and most developed countries will use neuromonitoring to reduce the risk of paralysis. So I would always start with probably most serious complication, but it's not frequent complication. So I think the quoted literature would be in the region of around 1 in 500 would be a reasonable figure to say. But you may want to, if you work in a deformity centre, find out what your unit's rate is before going forwards. And then there's obviously all the other general risks of surgery and spinal surgery that you can discuss afterwards.
Good. If someone is waiting for surgery and is treated with bracing at the same point, and if the angle progressed to less than 40 degrees, would surgery then be ruled out or still be indicated?
It would be very uncommon to have somebody on a waiting list for surgery who's in the bracing program with a view to correcting their curvature. So there are, I mean, unique, like because of the pandemic, some patients have been put into a brace just to try and slow down the rate of their progression, but they were already felt to be bad enough for an operation to start with. I've not seen it, you know, sort of dramatically improve in that way. I think most people would say to patients that what we're looking to do is stop the progression of your curve. So if a patient comes with a 30-35 degree curve, you put them into a brace, you're going to correct that curve in the brace, you hold it there until they're skeletally mature, you try and modulate their growth during the course of that time, but once you take the brace off, you expect it to be around about 30-35 degrees where you started. We don't often see a significant improvement in that, but you know.
Yeah, thank you. How do you explain the post-operative aftercare and follow-up, your own protocol after that?
Again, good question. So, I mean, the average length of stay, I guess, but these operations are between 5 and 7 days. Some children are so amazing and get out. I mean, I think the quickest has been 3 days from what I've seen, but the average would be 5 to 7 days in hospital. Their spine is immediately stable, okay, after this operation. So although they're going to be in pain and have a lot of discomfort as a result of their operation, I expect them to do physio and engage with physio from day one. And during the course of, I guess, the first couple of days, what we're looking to do is try and wean them off their opiates, get their catheter out early, try and get their lines and cannulae out early, and try and work on the secondary problems that happen while they're in hospital, which is usually constipation more than anything. That's the thing that really keeps people in, keeps kids in hospital, because they don't want to go in a bedpan and then too much pain to move into the commode and the toilet very early on. and then the opiates kick in and they develop constipation, ileus, and so forth. And it's almost like a vicious circle. And then we're trying to catch up with ourselves with laxatives and enemas towards the end. So, yeah.
Yeah, thank you. Do you usually combine anterior and posterior instrumentation for severe scoliosis?
So it's, again, a good question. So I think the most common way to treat even severe scoliosis is via a posterior approach. I mean, the pedicle screw has the ability to capture all three columns of the spine. Okay, so it is possible for you to get very, very good control of each individual vertebra, and your correction will depend on a number of things, but one of them is going to be how much release you do. So there are units in the UK who will be very experienced in doing anterior-based approaches to release the discs, which tend to be the driving force for the scoliosis. So if we, again, recall that this is a lordotic problem, if you take out the discs, what you end up doing is creating space for the spine to fall into. So you can recreate kyphosis by doing that. But you don't often, unless it's just a lumbar curve, you don't often just stop with a fusion of the anterior part of the spine. You end up doing a posterior operation as well, and so you are committing patients to two surgeries rather than one. And there is different school of thought where people are thinking about doing more aggressive releases from the back of the spine, so not just taking out the inferior articular processes, but also taking out the superior articular processes and the ligamentum flavum. So that's what is described as a Ponti osteotomy or posterior column osteotomy. And those are done just to get a maximal release from the back of the spine, so that instead of shortening the front of the spine by taking out the discs, you lengthen the posterior part of the spine by releasing the ligamentum flavum and the facet joint capsule as well. Each one has risks, right? Each approach has risks. So you're either going to have pulmonary complications on one side or neurological complications on the other. And a lot of this is going to be experience-based.
Thank you. Have you heard about the Shino-Jensingen brace? And if so, are they effective in correcting a structural scoliosis, or would one?
Yeah, Jensingen brace. I mean, basically, that's just a brand name for a brace that goes under your arms. Okay. Yeah. So the Boston brace was the first, type of TLSO, and I think the right phrase for these group of braces is a TLSO, so thoracolumbar-sacral orthosis, because that differs from the types of braces that they used to use in the old days, which is called like a Milwaukee brace. That was a C TLSO, and so Milwaukee braces were very, very uncomfortable for patients, but offered the ability to correct the proximal part of their curve. An underarm brace is not effective if the apex is above T6. And ginseng is just a brand name. There's lots of different private companies that produce these kind of braces, but most hospitals will use custom molded thermoplastic underarm braces or TLSO braces.
Yeah, thank you. What is your take on metacast treatment over the age of 5 and those with neuromuscular scoliosis?
Jesus, okay.
Yes.
Who are asking these questions? Again, metacast treatment. Well, I mean, metacast treatment or metacasting. Let's not call it meta. Let's call it what it actually does is EDF. So elongation, derotation, and flexion casting. So it involves basically anesthetizing the patient, putting traction on their body. So you're elongating the spine. Okay, you're derotating their chest wall, and then you're flexing them forwards. And that's done on a special sort of table, meta table, or Cottrell Dubois, who described the EDF technique, and is very, very effective. It's similar to sort of serial casting for limb contractures. It works in a very similar way. These patients need to come back every 3 months to have a new cast applied, and there are some risks associated with it because you're applying it, a rigid plaster cast around the chest, around the abdomen. Young children are mainly abdominal breathers, so they can get respiratory embarrassment with this. So you can't, it's not completely benign procedure. And patients who do have respiratory compromise, let's say an underlying syndrome, this really wouldn't be a suitable treatment for them, especially in an emergency situation, because nobody's going to have a plaster saw in their back pocket to take this off. But over the age of 5, it starts getting a bit more controversial. Many surgeons will sort of tend towards growing rod treatment, but I don't think it's harmful or wrong if you've got a well-structured casting service in your hospital to give that a try. I mean, I've seen some children up to the age of 10 going to some serial casts.
Okay, thank you. As a rule of thumb, would you say it's better to surgically intervene sooner for those with structural thoracolumbar scoliosis, i.e. when one is younger, early teens, or would you delay until later teens?
Okay, so I mean, I guess, yeah. So the question is obviously that there's more to that question. If they're younger, they've got more growth ahead of them, and so your metal work has to do a lot more to keep the spine straight. Because if they continue growing after your correction, there is a risk of something called crankshaft phenomena. So their spine could derotate out of plane, and their scoliosis could recur during growth. So there is some merit to trying to wait until they're a bit taller, but at the same time, a bit taller or a bit less skeletally immature. But on the other hand, if you wait too late and they develop stiffness because of structural change in their discs or structural change in their facet joints, then it is just a harder day at work, and the cosmetic result might not be as good.
Yeah, thank you. And what if the patient developed neurological deficit post-op? Observe or take them back to theatre?
Well, I mean, you try not to get yourself in that situation in the first place. So there are a number of steps that you will take surgically, and just depending on how you use your implants, you may put those in freehand or with fluoroscopy or using some sort of navigational robotic system. That's just with respect to implant placement. But even in the best hands, all of these techniques have a rate of screw malposition, and even robotics and navigation, is not 100%. So it's important not to get yourself in that situation to start with. Neuromonitoring, I think, really helps with that. So if you do pick up any neuromonitoring alerts during the course of your surgery, then you need to take steps to try and mitigate against those. So anesthetic factors need to be addressed. Maybe a low hemoglobin, maybe a low MAP. They may be too deep with respect to their sedation. The anaesthetist may have given them some paralyzing agent that hasn't worn off. There's a number of things, and there's some other drug interactions that can actually reduce the effect of or the sensitivity of your neuron. And you monitor sensories, the sensory evoked potentials, and motor evoked potentials. And there are, sort of alert systems and checklists that you can use to guide what to do. But essentially, you're trying to optimize the anesthetic side. You're trying to make sure that there are no technical things like wires haven't just been sort of pulled off, or those kind of things, like computers still working, etc. And then you start, thinking, have you done something? And so the most common thing to do is to just reverse the step that you just did. So if you happen to have just done the correction, you may take the rod out and just see if their monitoring comes back. Or if you happen to just put a pedicle screw in, then you'll take that screw out and then recheck it. And so you've got ways to intraoperatively palpate and check. If you're really concerned about the patient, then you can keep them under general anesthetic and take them straight for some 3D imaging, so CTN and MRI scan.
Yeah, thank you. And
yes, so the question was, if you picked it up post-op, I mean, try not to get into that scenario. But if you do pick it up post-op, you investigate that quick. Yeah. So time is spine.
Yes.
You don't want to sit on that.
Yeah. Do you give any temporary movement restrictions post surgery? No. If you go into the lumbar area, or brace patients post surgery?
Okay, well, so I mean, in terms of movement, they are going to be restricted in terms of their movements because their spine is fused, and so they've got to be taught how to get into and out of bed and how to get into and out of a chair differently. But by the time they come and see you 6 weeks down the line, they're just used to the new way their body works, and so physiotherapy will go through that with them on the first post-op day. And then in terms of bracing, I mean, there's no right or wrong answer. Some surgeons will post-operatively brace just to protect the patient from knocks and bumps and falls and just to slow them down. But other surgeons feel that by going through surgery, they've kind of earned the right to not have a brace afterwards, and they just let them go.
Yeah, thank you. I think that's all the questions. Now we are with the interactive questions. We have only one participant, but we hope that more will come through. We will.
I hope I saw Uche's name there. Is Uche still there?
We will just stop recording because people didn't like being recorded on YouTube.
No,
thank you very much for today.
Yeah, no problem at all.
Sorry?
Yeah, no problem at all.
Yeah, thank you very much.